Please be sure to like, share, and subscribe.
I remember being so scared that first night in the tent. I did not sleep a wink. Well, no. The guy, it started bleeding out of his eyeballs.
You are listening to EMS with your hosts, Erik and Matt Ball.
Well, it's kind of like what we're talking about today.
Yeah.
Something that matters, something we're going to actually use when we treat patients. Because these are emergencies that you may have seconds.
That's right.
And it really matters. I mean, you could be saving a life by doing something quickly here.
Yeah, and this isn't even just for providers. I mean, this is for anybody at home. You know, if you come across up on a car wreck or something happens at the house and, you know, you or a family member gets a severe cut, how do you manage that? Because obviously we have to have blood in our bodies in order to survive.
All bleeding does stop eventually.
Eventually, that's right.
You may not be alive.
That's right, yeah.
There are a lot of pearls of wisdom to learn here. The lecture we just filmed, but
a big
so what are we talking about?
Hemorrhage control.
Good.
Yeah,
Okay.
hemorrhaging. Yeah,
Hemorrhage
bleeding out. Yep. Yeah, the number one cause of death in trauma.
That's correct.
Yeah.
Yep, hemorrhage.
Yep.
And most of the time, as we talked about in the lecture, it's torso injuries.
That's right. Yeah.
But extremities can be injured. Junctional areas can be injured. We'll talk about
anything. Yeah. And I think so. The junctional or the torso. You know, why do we bleed out so fast with our torso?
Oh man, you got some big old vessels in there. Right. Yeah, it's all like we talked about in the light board that we did.
Yeah.
Bleeding out is typically not a pump problem. The bleeding out is usually a hose problem. We have these blood vessels in our body, and they deliver blood to the organs to keep them perfused.
That's right.
And when you have an injury to part of your body, you're going to be injuring some of the hoses. And you know, if you're running a large diameter hose out of a hydrant and you bust it, or a car drove over it and it's hemorrhaging water, you're not going to generate much pressure at the pump, right?
No.
So there are a lot of different problems that can happen physiologically when we damage a blood vessel, but there are a lot of things that we can do to fix it.
Yeah, it's it's a relatively simple fix in theory, that we have to stop the bleeding, right? We have to close off that whatever it is that's leaking, right? Just like you said with a hose, you got to shut down that line, and then you've at least stopped the progression of the damage, right? And then you have to replace what you've lost, like we talk about in our lecture. And so that's the biggest thing, whether, again, you're a EMT, a paramedic, a nurse, doctor, or a layperson, is if you see somebody that has significant bleeding, and talking about significant bleeding, and I'm sure you've seen this too, I'll never forget, one day we were called out to a hemorrhage call early in the morning, 4 or 5 a.m.
Right.
And we're going to this call, and I'm reading the notes on the computer, and it says, daughter has a nosebleed, and in the notes it says massive amount of blood. And I'm like, okay, wow, you know, I mean, again, going back to our theory of there's small vessels in the nose, you know, but you can bleed a lot through your nose, for sure.
I got a story to tell.
Okay, perfect. So we show up, and this guy answers the door, and he's this big, muscled up, mean-looking dude, right? And he is frantic. He is freaking out. And I'm like, what's going on? Oh, my daughter's got this nosebleed. And we're like, okay. And then the wife comes down. She's got the daughter, and she's kind of holding pressure on the nose, and she's got her head tilted backwards. And I'm like, okay, first off, let's not tilt her head backwards, you know, because then the blood goes down into your throat, all that stuff. So I'm like, just pinch it for now. He goes, her whole pillow was covered with blood. We heard her crying. We went into her room, and the whole pillow was just saturated with blood. And I'm like, could you go get me the pillow so I can see for myself how much blood we're talking about here? And so while he's doing that, my partner's checking out the kid, you know, doing all that stuff. And this dude looked like an ex-Navy SEAL. I mean, he just had this look like this dude probably knows what a lot of blood. He comes down, and there is like 3 little drops of blood on the pillow. And I'm like, I think she's going to be okay, you know, but it was funny.
You probably didn't say that.
I did not say. No, I did say. I said, I think she's going to be okay. I said, this is, you know, I didn't.
You didn't say you idiot.
I did. I thought it, but I didn't say it. Yeah. No, I mean, and I get it that when you're a dad, I don't care what your experience, when it's your little baby girl or baby boy,
I know.
you're freaking out. So, no, she, you know, was fine. But
they studied this. we are really bad at estimating blood loss.
Yes.
Even us medical professionals.
Yes.
As much as we want to say you idiot,
That's
we have been studied, and we're really bad at estimating blood loss.
Yeah, didn't they pour it on the ground or something like that?
Yeah, they poured it on the ground, just a X amount of blood. I don't know how much it was, honestly,
Right.
but they went and asked medical professionals to enter that scene to estimate the blood loss in the wherever,
Right.
in the kitchen with all the blood everywhere.
Yeah.
And the variety of estimations was astounding.
Way off. It's kind of like palpating pulses or needle decompressions.
all
It's
that.
all over the place. Yeah, that's so funny.
I had a patient with a bloody nose once, and this guy came in. His nose was, and honestly, 99% of bloody noses I can take care of,
Right.
and send them home, and they'll follow up sometimes with an ENT. Sometimes I'll just tell the kid to stop picking their nose, or
Keep
it's
it
really
moist.
dry outside, keep
Yeah.
it moist,
Yeah.
or or whatever. Maybe stop your blood thinner today and see your primary care in the morning or whatever.
Yeah.
But so it's a pretty common thing. But I had one guy that came in with a bloody nose, and I will typically pressure for a little while, see if we can stop it. But he was bleeding pretty heavily. I mean,
Yeah.
it was a pretty impressive nosebleed, and I've seen a lot of them, so to impress me was something. And so I thought, okay, well, I'm going to skip my typical, Afrin in the nose and wait, and I'm gonna put in the balloons. So put in bilateral balloons in this guy's nose after spraying with some Afrin, after I cleared the blood or whatever,
Right.
and they hurt. Got them both in, pumped them up. The guy's pretty uncomfortable, and he's like, "Man, I'm bleeding. I can feel it going down my throat."
Feel it backing up, yeah.
So we had a pretty impressive nosebleed. So I'd put in some of the shorter ones. I should have put the long ones in. So I went in and I put the long ones in, and I really
Balloons?
yeah, for posterior bleeds.
Okay.
Is what I did. And typically I went through all this without contacting my ENT. And anyway, the guy, the blood stopped going down his throat, so I thought I'd got it. Right. Well, no. The guy, it started bleeding out of his eyeballs.
Oh gosh.
Yeah, the lacrimal duct are connected to the nasal cavities, and they drain
Why
down
your eyes
into
water when you get punched in the nose?
yeah, well, it's all connected.
Yeah.
Anyway, so he was literally bleeding out of his eyes, and I could not stop the bleed, and I ended up contacting the ENT. They came in. Anyway, it ended up going to the cath lab. They embolized him.
Oh wow.
They went to the cath lab to stop the bleed. It was a big posterior bleed, and I can't stop that, right?
Yeah.
So that was the worst nosebleed I ever had. The guy literally bleeding out of his eyes.
That's crazy.
I'd never seen that before.
Did
the ENT was pretty impressed too.
No
when you impress
TXA?
an ENT with a
Oh yeah,
nosebleed.
who sees this every day? Yeah.
Well, that's a good point. Yeah, I actually got a medcom call not too long ago from one of my paramedics, and I walked him through, saturating some gauze with TXA and that's not FDA approved use of TXA, but boy,
we're finding a lot of things out about TXA that it has use for.
Yeah.
Yeah, we got called to an e-care one time for a hemorrhage. Showed up and went in the room, and the doctors and nurse, they weren't freaking out, but you could tell they were a little excited. And walked into this room, and this lady's sitting there, and she's got, you can tell she's got stuff in her mouth, and they've got 2 IVs, fluids, and I'm like, what's going on? Well, she had impacted wisdom teeth removed. She had a dry socket, popped a little artery, and they're like, we cannot get this thing stop bleeding. So first off, I was like, okay, well, let's shut down the IVs, right? Because we don't do that anymore. We don't flood them out. So I'm
Nice
like, let's
work.
shut down the IVs. And then got her in the ambulance, and we had TXA, and we were, it was in our protocols to use it for nosebleeds, the gauze soap, but it wasn't in our protocols to do it for oral bleeding.
Which is actually one of the 2 FDA approved uses.
Oh,
Isn't
really?
that funny? It's indicated, FDA's approved it for 2 things. Maternal, like OBGYN hemorrhage,
And oral.
and
Dental.
And it's not in your protocol.
Well, this was also probably
offense.
10 years ago. This was a while ago.
okay.
Yeah,
So
this
it's
was
in there now for sure.
Oh, yes, it is in there now. Yeah. So I called my medical director at the time, and I was like, hey, this is what I got. And I said, is it okay if I, do this? And he goes, oh, yeah, absolutely. And so that's what I did. I put it back there, said, hey, bite down on this. By the time we got to the ER, she had stopped bleeding.
Yeah.
And so it really worked well. And so that goes back to our hemorrhage control. Like, you have to consider, where are they bleeding? And there's a great diagram that I can maybe put up here that I found. I love this diagram. I use it all the time when I'm teaching, of how to stop bleeding depending on where it's at. And so if it's an extremity, shoulder or hips down, tourniquet, right? And typically, as most people know, especially on a thigh or a leg wound, you probably are going to need 2, right? So for those providers,
definitely usually need 2.
Yes, because again, you've got big hoses.
Big hoses and a lot of tissue.
Exactly. You've got to get through that tissue. So tourniquets on extremities, junctional areas, so shoulders, hips, things like that. That's where you'll use your combat gauze.
Or there are junctional tourniquets too. They're not commonly used, but they are.
Israeli bandages and things like that. They're helpful with, but still you can pack
still pressure,
those
basically.
Exactly. And you can pack those and then put like an Israeli bandage over that. And one thing to keep in mind for our providers, EMTs, paramedics, if you have those type of injuries, if you have some sort of combat gauze, you want to pack that wound as deep as you can, as tight as you can, and then if you run out of that gauze, just take some cling, and you want to fill that hole up. And if you don't have combat gauze, just use the cling. Take that out, clean it, and pack that wound as well.
The other thing worth mentioning now is the pelvic binder with pelvic fractures, with traumas, and unstable pelvis. A pelvic binder can limit the amount. It doesn't stop the bleeding, but it can limit the amount of blood that can be bled into that cavity. Which is usually 1 to 2 liters. You don't put them in a binder, you run the risk of over bleeding and then getting close to that end stage of hemorrhagic shock we talked about. How much blood can you bleed into the belly? Well, all of it.
All of it.
Chest is big too. A hemothorax of some kind can be bad. But those torso bleeds, we can't really fix those. We might be able to help mitigate some of the bleeding, but we got to get them to the place that they can get fixed quickly.
Yeah, and that's with most trauma is, we've got to, we preach all the time about like medical cardiac arrests or things like that. Stay on scene, treat them on scene. We're not fixing, most of the time in a medical cardiac arrest, it's a pump problem. Obviously, I'm not fixing that problem. They probably need a cath lab, right?
Without you, their brain cells would die. That's the reason we're doing it.
Yes, we're trying to keep the brain alive. Yep.
And the best of chest compressions are only given 20 to 30% cardiac output, and that might be enough to get them to the hospital where when they get the ROSC and get everything reperfused in the brain, we haven't lost too many brain cells, and we can leave the hospital.
Walk out.
That's the goal. That's the end. That's the outcome measure that really, and we're not talking about cardiac arrest, but
there's so many points we could talk about.
But as far as bleeding goes, early recognition is key. Early recognition is key, and then stopping the bleed.
That's right.
Because you may not be bleeding from an extremity, right?
Right.
You may be bleeding somewhere else, and getting them to a place where they can get it stopped as quickly as possible is the key.
Right.
You don't want to be dancing around on scene and realize, oh no, we've been here for 10 minutes. They've been bleeding in their belly for 10 minutes. You may be in a world of hurt and killing your patient.
That's right. Any of these skills you can do, you can obviously on scene, I'm going to throw a tourniquet on real quick, but if I'm seeing squirting pulsatile flow of blood, bright red type blood, I know that's probably arterial, and that turns up my time clock, or, that's making it fast. I got to move. And so throw on a tourniquet, and again, tourniquets are simple to apply. You should, I always, not always, but occasionally I will go into our bag that we carry on our cot in the ambulance, and a lot of times they'll only have 1 tourniquet in there, and I always have 2 in there. Always have 2, because if I'm going into an apartment or off somewhere in a wreck and I show up, 1 tourniquet might not be enough. So tourniquets are very simple to use. Obviously, make sure, like we said in our lecture, you're using approved CAT-style tourniquets, or else they might fail when you need them to not fail. But practice with them. If you're an EMT, because another thing, and we talk about this a lot in our lecture, if you work out in a rural environment, or maybe if you work in a real urban environment and you have, unfortunately, a lot of violence, and you see a lot of gunshot victims, maybe you're used to working trauma. I know, like in my department, we work in a subdivision of Dallas, or in a suburb of Dallas. We don't get a tremendous amount of trauma. I mean, we get car wrecks and things like that, but we don't get a tremendous amount of trauma. So tourniquet placement is one of those skills that you need to practice. Get it out, throw it on. Important. It's so important because, like you said, when you need it on, it's got to be put on quickly. And so we got to be proficient at that. But these, get them on the cot, get them in the back, and go. You can start IVs en route. You know, especially if you're rural service, you really got to get moving, or call for a helicopter, you know, to get them to a trauma center quickly. And then get them to you guys at the facility that can treat those. Don't take them to a level 4 trauma facility. You know, I mean, obviously follow your protocols. But
unless they're unstable and they've gone into cardiac arrest, there may be a reason to leapfrog it from the closest possible.
You have to get, because even a level 4 trauma center with a physician and nurses is going to be better than, you know, an EMT and a paramedic in some rural area. They still have a lot more resources, but. And then torso, you know, we don't want to pack. I've seen this before. A lot of people think, oh, well, I'll get the combat gauze. You get like an abdominal GSW, and people want to start packing that, and that's a bad idea. You know, you can.
Yeah, those GSW, those wounds are usually pretty small, and trying to pack it, it's not a good idea. It's not going to do much good. The damage, actually, that cavitation wave through that damages the tissues. I mean, you just got to get them to the surgeon and get them there as quick as you can.
Open them up.
And they're probably bleeding internally with a vessel injury that you're not going to be able to get near. So, you know, mucking around with trying to pack a little tiny hole. Yeah. The damage is inside.
Yeah.
Anyway, so we there are many causes for hemorrhage, and so when we were planning our lecture, we wanted to, you know, what are we going to focus on? Are we going to focus on MVCs, which is the most common, or violence, stabbings, gunshot wounds, MVCs?
We went a whole other direction.
We totally did. What did we do?
Well, what did you do? I didn't do anything. You did it.
Well, the idea, right?
Yeah.
You know, was to do something that would be interesting, and so we picked, you know, of all the animals on the planet, in all the situations somebody could be in.
Two that I could think of. That would probably be, there's 2 animals I could think of that are scariest, but the environment of that one is the scariest.
I think so. I mean, we learned a lot of sharks.
Yeah.
Is that not only are you not a fish and not a fast swimmer.
That's not our natural environment. Yeah.
We talked about this. Michael Phelps swims 5 miles an hour.
5.
And
you asked me, and I think I said like 20 or 30. You know, I thought, oh, you know, Michael Phelps probably can motor. Nope, 5 miles an hour.
Yeah. And sharks, the great white sharks, swim at 46 miles an hour. Oh my gosh!
At 1 or 2 tons of weight.
Hey, if I see a shark, I'm just going to swim to shore.
Well, and that's what you said is when you talked to the doctors out there, the shark experts, and you're not going to see these things.
No. They attack from underneath and behind. They are expert hunters. They use their electroreception to orient their mouth with your body. And they're 23 feet long, thousands of muscle,
5 rows,
4,000 psi bite, 5 rows of 2-inch long razor sharp daggers. That alone created the recipe for massive hemorrhage. And we talked to the ER doctors that described these wounds as more of like, it looks like a grenade blew up on the guy's shoulder. We actually got to talk to a shark bite victim that was on Good Morning America.
That's right.
And he agreed to be on our show, and we got to interview him, and he survived. He got bit by this great white left shoulder. He was actually a left-handed pitcher.
Yeah.
Took out his left shoulder. Now the guy, he such a brave, inspiring kid, wanted to go back and become a lifeguard.
Went right back in the water. Yeah. I wouldn't get into a kiddie pool after being bit by a great white shark.
I felt like such a wimp, as scared as I was out there, where these people were bit and killed. Multiple. We learned that it's a great white nursery.
This is in California.
Just San Diego area, just north of San Diego.
Was this Beacon Beach?
Well, there are multiple different beaches around the Del Mar area.
Okay.
And Sanitas, but there's these are where these bites had taken place, and it's just considered a great white nursery. We learned that from Dr. Lowe up at Cal State Long Beach, and we decided to go out swimming out there, and that was one of the scariest things I've ever done. You got to check out the video if you haven't seen it. It's some of the footage we got was crazy. We held rattlesnakes. We did a lot of crazy stuff.
Oh, you did.
This was not so.
That was
not so.
Yeah, because you'll survive a rattlesnake bite more than likely. It's going to suck, but you're probably going to survive it. Yeah. And I mean, I think, didn't he say you have a greater chance of getting struck by lightning than get bit by a shark? Something like that?
That's true.
Yeah.
I mean, the chances of getting bit by a shark were really, really low. It's just the thought of what was lurking in water I couldn't see, and I was, you think about it. You got surfers out there that are getting bit, or swimmers. They're moving around.
Yeah.
I was sitting in the same spot. I was told to stay in the same spot.
Thanks, Devin.
Because he was flying the drone over us, getting some. Right. We coordinated our lines to line up with the audio recordings, and so we had hand motions of when he was bringing the drone in, and we've hand motions when we were ready. And
what was the hand motion for hurry up? Let's get this done, Devin. Yes.
We were freaked out. Oh, actually, I was freaked out. Dr. Schwartz, who is the medical director for San Diego out there, he was not freaked out. In fact, he was like hitting my leg. Did you see that?
He would have gotten punched. Yeah, that is one of my, I go backpacking, and like my wife is terrified of bears. She doesn't like going out. And I'm like, I get it.
She's a smart woman.
Yeah, a grizzly bear, that would be terrifying. However, when I go backpacking, I usually carry something with me to keep me safe, So I have that option.
Yeah.
Plus, I'm in my environment on land.
Yeah.
Dude, when you're in the water...
Yeah, you can run, maybe climb a tree. They can climb trees too, but at least you can get up in an area where you can defend yourself a little bit with your handgun. It better be a large caliber handgun.
Yes.
Otherwise, you're just going to piss them off.
Yeah, exactly. You don't want to shoot them with a 9mm. That will make them mad. But a shark, you're not. There's nothing.
Did I ever tell you the story when I went up to northern British Columbia to go camping?
Was this your
Portage trip?
Yes.
Okay. They used to call this lake, it's the Bowen Lakes is where I went. Wonderful trip.
Yeah.
They used to call it the Bear Lakes because there's so many grizzlies up there.
That's terrifying.
And I remember when we were at the ranger station, they were telling us, don't use deodorant. They smell that. Don't cook spiced meats or eat like onions. Don't brush your teeth. No soaps, no shampoos. Just use the mud to wash off and stuff. And the first night, my uncle had bought kielbasa with onions. I'm not joking.
All the wrong food.
All the wrong food.
Took a shower. Sprayed some. Had some cologne on.
Oh, I mean, I remember being so scared that first night in the tent. I did not sleep a wink.
I don't blame you.
I was so scared. And the next night, I'm like, okay, I'm getting to sleep tonight because we got a cabin the second night.
Yeah.
There's like these cabins you can stay in. And I remember thinking, okay, tonight I'm sleeping. And I'm just about to go to sleep, and this muskrat kind of climbs through the chimney of this cabin, is on, I can see it, on the table in there, this giant, prehistoric looking mouse, rat, huge things, trying to claw into our food supply. I threw my shoe at it. I didn't sleep at all that night. I was imagining this thing.
Terrified of the muskrat.
Anyway, being in the food chain though, with that, imagining those grizzly bears. Now they run about 40 miles an hour, and I can run about not that.
Yeah. No.
And that's scary too. But
massive,
the sharks.
Yeah, that's just terrifying.
Yeah. But back to hemorrhage though, when a shark bites someone, it's an explosive injury, like those ER docs describe, like grenades. It's when. Remember the bleep moment that Keene described?
Yeah.
He got bit, took out his left shoulder. His arm was disarticulated. It wasn't detached yet. It was attached by soft tissue, but he saw the head of his humerus. I mean, he's looking at his arm and blood everywhere, squirting blood. I mean, and then
you're
the guy
in the
in the
water.
kayaker says, "Oh."
Yeah. Oh.
And he was saved, obviously, and what a great story. But when these sharks bite, they cause massive tissue injury.
Yes.
Massive tissue injury. I mean, they're biting limbs off.
Yeah.
I mean, with a 4,000
Yeah,
PSI
Bethany
bite.
Hamilton.
Oh, yeah, right. So it's really important for these lifeguards who taught us how to use tourniquets to know how to stop the bleeding if they can, or transport quickly to a place where they can get fixed.
That's right.
And a lot of these folks die.
Yeah. Oh, yeah.
Because
Massive
they
hemorrhage.
get bit by, you get bit in the leg, that femoral artery is going to bleed you out quickly if you don't get the bleeding stopped.
Yep.
And so that's what's killing people out there.
Yep. Yeah, it's super important to know how to manage these patients as providers. Again, pressure, put something on it quick, get some pressure on it fast. You can makeshift tourniquets. There's all kinds of videos out there on if you don't have access to a cat tourniquet, you can do different things. But pressure, stop the bleed. When I was in paramedic school, tourniquets were like, oh no, you don't do that.
Yeah.
And it's so interesting how, in medicine, things come back around, and now it's like, oh yeah, you 100%. we had no tourniquets on our ambulances. That was a big no-no. You didn't do that because you were going to cause, damage to the tissue, and they were going to have to get it amputated. And now it's like, no, they can keep them on for, a certain amount of time. But yeah, it's super important to know how to manage these patients.
Absolutely.
And fluids, like you said in the lecture, replace what they lost. They didn't lose normal saline or LR.
No,
they lost blood. And so if if you have access to blood, that's what they need. Before, until they get the injury fixed. If you don't have it, maybe you could call a flight team or something that could come out, or maybe a local department has it. And then obviously, if nobody has, if that's not an option, you got to go. You got to get them to a facility that has some blood.
What you said is probably the biggest pearl or morsel that we discussed in our lecture that's important to take away in managing major hemorrhage. Some of the other things we talked about were recognizing the stage of hemorrhage that you're in. That can be important too. The first thing that changes is the vasculature changes.
That's right.
The very first thing that changes. But it won't show up on your vital signs. Your vital signs will be normal. When you start to see the vital signs change, your heart rate starts to go up first, and then the blood pressure eventually will come down when that compensation doesn't work anymore, and then you start getting altered mental status. Now you're circling the drain.
Yeah.
So it's really important to try to figure out, with all the other complicating factors, is this person going into shock or not? That can be tough.
Yep.
Like we talked about the shock index.
That's
we
right.
talked, heart rate over the systolic blood pressure.
Yep.
But recognizing the signs of massive blood loss is another key thing we learned. We talked about TXA, some of the other things we can do besides tourniquets to stop bleeding, pressure.
Yep.
And then I think one of the other things that we talked about is the permissive hypotension.
Yes.
Another key.
Yes. 120 over 80 is not necessary on massive trauma patients. If you got a blood pressure of 90, I'm perfectly happy with that.
Yep.
Yeah. So don't get too crazy that, oh my gosh, we got to give them fluid because their blood pressure is 90. Nope, they're good.
Yep. The days of doing that, slamming a liter of fluid on a trauma patient should never be done again. That's hurting people. It's making their blood dilute, so it's
blowing clots
fast, and then it also causes increased leakiness of blood vessels. So it's really not recommended to do that. Now follow your protocols, obviously, but I don't care what your protocols say.
Yeah. If they say give 2 liters of fluid in a trauma, then you need to relook at that for sure. And again, watch our hemorrhage lecture. We go into way more detail. There's 2 parts. It's a 2-hour lecture.
And it's fun. We're out there risking our lives with sharks. And
I wasn't crazy enough to go do that.
You were with me in spirit. I can't remember. You helped me plan it, but there was something going on. You couldn't travel with me.
I don't remember what it was, but it was because it was, I don't
Devin
remember.
and I talked about you at the time. We're like, man, wish
that
Matt
idiot,
was here.
that chicken didn't come out here with us.
No, it was it.
That's what I would have said. No, it's a great lecture, very entertaining and very informative, and a really important topic because we need to know how to manage these patients pre-hospitally.
And I think the cool thing for me about that lecture was, I think it was like that's really, if you want to see what we're all about with education, we take great content and we package it in an interesting, engaging format. It's more like a show, really. We have fun watching it. You learn a ton from experts outside of, we're experts too in some ways, but getting the other experts out, it just made it so much fun. If you haven't seen a lecture from us, you got to check it out. ActSceneCE.com.
Yep, we got the link in our bios.
Should be putting it up on the website shortly.
Yeah.
So just keep an eye on it.
Well, see you on the next one.
Be safe out there.
Thank you for listening to EMS, the Erik and Matt Show.